Okay, so we're going to talk about what's new in trauma resuscitation. Let me find my clicker here. I have nothing to disclose except for my little I love trauma. We had a busy week this weekend, so I'm a little tired. So try not to hurt yourselves coming down the stairs. So this is a journal article that was published in 1983 that was published by Don Trunke. He's one of the fathers of trauma. And he stated back then, and it's still true today, that accidental and intentional trauma is a huge loss of life in young people. Those under 40 is what young people is defined as. So, and among the prescribed remedies, improved preventative efforts, speedier surgery, and further research is really what was needed. Back then, we were just babies and trying to figure out how to resuscitate traumas. So the causes of trauma death include two big things. And this includes in the first 24 hours of somebody who's has an acute injury. 50% of deaths happen because of hemorrhagic shock, and the other part is neurologic injury. And what we're going to focus on, because this is a resuscitation talk, is hemorrhage, and not so much the neurologic injury. That would be a whole nother talk. So my clicker really doesn't work very well. There we go. So in 1983, what Don Trunke looked at was when do people die in trauma? And there was a trimodal distribution of death in trauma. And you can see that early in the first hour or so was when a lot of people would die. They would die at the scene or they would die en route. And a lot of these trauma deaths, we have to look at preventative measures. So helmets and seatbelts and things like that, that's what's going to help these patients. If you look at the second hump, it's within the first few hours of the people getting to a trauma center or not getting to a trauma center in some places. And this is what we call the golden hour. This is where the golden hour kind of came about, in that this is where we could really make an impact on people who were victims of trauma. And then the late deaths were the people who were lingering or languishing in the ICU, who had multi-system trauma, who died of sepsis or died of other things that would cause them to die. We looked again at this data. We looked at the National Trauma Data Bank, and in 2010, this is published, and we turned our trimodal distribution of death to a bimodal distribution of death, because we think that our critical care has gotten better. Our ability to treat sepsis and to treat the things that people died of late, including ARDS and all the other things that everyone talked about today, got better. And what we still really need to focus on is that initial phase, which is the immediate deaths, which are preventative measures, and the measures within that golden hour. So that's really what we're focusing on for resuscitation. So this whole concept of damage control resuscitation has come into play in trauma. And it's first started out as just being damage control surgery. But now we're looking at damage control resuscitation in these patients. And there's a lot of new concepts that are very, very difficult to implement and change the minds of people who take care of trauma patients. So what is damage control resuscitation? What it means is that we minimize blood loss until definitive hemostasis is established, which is a huge statement, because it requires a whole lot of intervention in order to accomplish this. So we temporarily sacrifice perfusion for hemostasis. In other words, the scoop and run concept, where you put the person in the ambulance, you get them to the nearest trauma center as soon as possible, and then you start to take care of them. You don't wait in the field, put an IV in, intubate them, all those sorts of things. So how do we do this? So first thing is we have to focus on the hemorrhage control part. The second thing that we do is we concentrate on permissive hypotension and hypovolemia, and then prevention and correction of trauma-induced coagulopathies. So blood-balanced product resuscitation, as well as minimizing crystalloids. And we've moved away from using crystalloids and moved towards using whole blood, or components that make up whole blood. So the outcomes of this have been that we have a decrease in mortality intraoperatively, but also hospital length of stay, improved coagulation profiles, and reduction of crystalloid and vasopressor use in our patients. And you see no longer these really, really puffy patients who have edema all over their entire bodies. And you now see the patient who has something that they should have died from, walk out of the hospital in 4 days. So you can actually see this happen over the years as we've changed our viewpoints on trauma resuscitation. So concentrating on hemorrhage control, we have many, many ways to do this. Just simply the thing that you learn in grade school, which is if you see something bleeding, hold pressure. It's something that we always forget about, but it's a very important concept. If you see somebody who's bleeding, hold pressure. The American College of Surgeons has teamed up with the National EMT Society, and they've brought on a campaign called Stop the Bleed. And we've brought tourniquets back into civilian use in teaching civilians how to use tourniquets again. And so people can get certified, especially physicians, and we're trying to train through our emergency department even, how to teach civilians to put tourniquets on so that we can have bystander hemorrhage control in the field. This was a big thing that came about after the Boston Marathon bombing, because there were many people who put on tourniquets on the people who were injured in that scenario. And even in Las Vegas, this also came into play. In Oak Lawn, when we had our massive training, our mass cash, we also, the city of Oak Lawn has bought large tourniquet kits that you can take to scenes and things like that, so people can put tourniquets on people. I have one in my car. So things that we can do in the emergency department, such as splinting. I'm going to talk just briefly about RIBOA, interventional radiology and surgery, which are surgery, one of my favorite things to stop bleeding, but also needs to be available. And it becomes a big deal if you're in a situation or in a hospital where you don't have surgical services to stop bleeding. So RIBOA, I just want to talk about this a little bit. This is one of those sexy new ways to take care of bleeding control, which is a resuscitative endovascular balloon occlusion of the aorta. And what that means is that we put a balloon into the groin and we snake it up into the aorta and we blow up a balloon so that we can essentially clamp the aorta and allow more blood to go to the brain and to the heart than into the lower extremities, or even stop bleeding in places where people might be bleeding, such as the spleen or the pelvis. And if we blow up this balloon in these different zones here, you can get occlusion of the aorta from here down, and most of the blood flow will be directed to the important places like the brain and the heart. This has become something that we put in the emergency department, and in some places they put it in the field, especially in combat areas. But there's been a lot of controversy as to how useful this is and who should be putting this in and whether the complications are worth it all. So we're still kind of in debates. My general bias is that I still have yet to see that it can be universally used in trauma patients, and there's a subset of patients who I think may benefit from this. But it really just depends on where you are, what your EMT is like, what kind of hospital you work in, how available your OR is, how available your IR is, and all those sorts of things. So it really comes to that. In Japan, they were using it in the field, and they were leaving it in for a long time. And we don't really know how long you can leave this in either. So it was associated with higher mortality there. And there was just a recent publication that looked at the National Trauma Database and RIBOA using it in patients. And we just look at, it's a national trauma registry where we looked at whether or not we were actually saving lives with this. And there was a higher 24-hour mortality, renal failure, and amputation rate in patients who got it. No difference in intervention, blood transfusion, length of stay. But remember, these are trauma centers that are reporting this, so they have all of the tools that they can use to resuscitate and stop blood control. Whether or not it's going to help in smaller hospitals or things like that, we don't know. And is it being put in the appropriate people? That's something that we're still trying to figure out. So it is a tool, still trying to find where it's going to fit into the grand scheme of things. Permissive hypotension, though, is a really interesting concept that has kind of, as a necessity in combat, we draw a lot of what we do in trauma from combat zones, from wars. We've learned a lot about trauma resuscitation and trauma care from those situations. And in Iraq or in Afghanistan, when you get shot, 2 or 3 hours away from where you have definitive care, permissive hypotension is almost just because that's all you have, as opposed to something such as here where we have shorter transport times. And so do we need to apply permissive hypotension to our patients in civilian trauma as well? So what this does is prioritizes hemorrhage control over perfusion. And normal may not be 110 in a MAP of 60, but it may be a blood pressure, systolic blood pressure in the 70s, 80s even. And that's really hard to watch on a monitor. It's hard to watch for any of us until you get definitive care. So we might have to change our goals. And recognition of shock is not easy in a trauma patient. We have, in general, a young person who is in a major trauma, either motor vehicle collision or penetrating trauma. And identifying if and where there's active bleeding is also difficult because you have this skin that's over your body. If it's somebody who's shot, it's usually around the area that they're shot in, but if somebody's in a motor vehicle collision, it's often very difficult to tell where they're exactly bleeding from. It's sometimes not obvious in the vital signs. Excuse me. And sometimes there's controversy over initial fluid, whether you have blood, whether you have a fluid bolus. And scoring systems have been utilized and tried to be applied to these patients. So if we could score people on what their vital signs are and how they look and what kind of mechanism of injury did they have, can we tell based on these scoring systems whether or not people are in shock or not? And it turns out that it's no better really than just the clinician looking at the patient saying, this guy looks like he's bleeding. So it's very difficult to identify and determine whether or not people are in shock. So I'm going to just talk to you about a patient I had the other day. So this is a code yellow who came in, code yellow being a trauma. He came in at 20:55. He didn't arrive to 21:08, so he's in the field for several minutes, and his blood pressure when he got to us was 120/80. His heart rate was 100. 20-year-old guy. It was 20. He got 200 mils of crystalloid in the field, and he got a chest X-ray and an abdominal X-ray. And if you look at the red dots here, this is where he was shot. 3 times here, here, and there, and there. He had no pulse in either of his radial arteries, thready pedal pulses, and those were his vital signs. About 5 minutes later, 3 minutes later, after we got our second set, his next blood pressure was in the 70s. And so he deteriorated very quickly, and we got him to the operating room. We have blood in our emergency department, so we gave him a unit of blood on the way up. We got him to the OR in about 21 minutes. And his initial lactic acid, after he got that first unit of blood, was under general anesthesia, was not until he got into the operating room, was 3.3. And he wasn't actively bleeding outwardly. He had a little bit of abdominal pain. He ended up having a liver injury, a kidney injury, a colon injury. So he had an exploratory laparotomy, and he also had a brachial artery injury for which he had no pulse in his arm. So we were told also from the scene that he bled a lot at the scene, and a lot is very hard to quantify. So you don't know based on that initial vital sign or whether or not what they have coming in. We were told he was stable on the way in, or even how much blood you lose at the scene. I mean, a lot to one guy is not a lot to another guy. So it's very difficult to tell in these trauma patients sometimes, and you have to give them a little time to evolve, but also have a high index of suspicion for the type of injuries and the patterns they have. So now that we know that he's in shock, how severe is it? Well, coronary and cerebral perfusion are the most important things. Maybe it's just we need to maintain a palpable femoral and carotid pulse, because that's all we really need to do in order to maintain perfusion to the heart and lungs. And that's kind of what this guy had. He really didn't have a very good pulse in his pedal or his radials. And then end organ perfusion, base deficit and lactate, and capnography can be used to monitor how well the patients are doing. Massive transfusion protocol. So I'm going to talk about this a little bit because this is part of damage control resuscitation. What it is a protocol that allows us to give ratios of blood that look like whole blood in a massive fashion. So massive transfusion is defined in trauma as 10 units of PRBCs or more that are given to a patient. It doesn't quantify really FFP or platelets or other products. But it's improved patient survival to have a protocol ready. So if you have a massively bleeding patient from trauma, you can improve survival by having this in place and having your blood bank ready for this. It's also been shown that you actually decrease the number of blood products that you use, and you decrease wastage. And part of the reason we think that you decrease the number of blood products is because you don't only give red cells, you give FFP and platelets and things that will help you clot. So you decrease wastage and you decrease the amount of blood products that you use. And we want to prevent resuscitation coagulopathy. So if we looked at the proper study, which looked at the ratios 1:1:1 versus 1:1:2, the 1 and the 2 being the amount of PRBCs. So in the second, the 1:1:2 would be 2 of PRBCs to every 1 of platelets and 1 of FFP. There was no difference in mortality because in reality, if you're ordering off FFP, it has to be thawed. They have to give you another extra few minutes to do it. So a lot of places, in reality, we don't give a 1:1:1. We give a 1:1:2 or around that. But there was no difference in mortality between those two. And whole blood, in fact, going back to whole blood, the walking blood bank that the military has, because when people bleed in the military, you donate blood and you have your walking blood bank. But we're going back to whole blood. And actually, in the Chicagoland area, Christ Hospital is the first trauma hospital to pilot a whole blood program in which we are kind of getting along as much as we can. It's kind of becoming something that is going to be more and more seen in trauma centers. And unfortunately, because the demand is high, whole blood is on demand for many of the blood banks who can't provide it at this point in time. So, but in my experience, in the few patients that have had whole blood, it's wonderful because they get all of the products, all the clotting factors, all of the things that help you clot in addition to replacing blood. So what we're looking at even more is, do we give blood earlier than when they get to us? So the refill and the combat trial are in process right now, trying to look at that as a potential. So what's wrong with crystalloid? I mean, we used to, in ATLS, Advanced Trauma Life Support, say, oh, we always give 2 liters of fluid right off the bat. Well, we're seeing more and more that even as little as a liter of fluid in the trauma bay in somebody who's acutely bleeding can cause coagulopathy and endothelial damage and tissue edema and worse outcomes in these patients. And so if you do use fluid, what fluid can you use? And we even debated about this, hypertonic saline versus crystalloid versus plasmolite. Plasmolite, which is a balanced solution, is what we've moved to in our trauma bay for our trauma patients because its pH is more normal, 7.4. It's actually kind of nice. And so we avoid that coagulopathy that comes with acidosis as well. But still, it's a crystalloid. And compared to blood, that really hasn't been shown yet either, whether or not it's superior to other crystalloids, but perhaps not necessarily superior to blood. And then tranexamic acid, which is also been looked at in the CRASH-2 and the MATTERS trials. MATTERS being in combat, CRASH-2 being in about 240 hospitals across Europe and Australia, I believe. And they looked at overall mortality of using TXA. And the patients that benefit are those that are in shock, those who get it within 3 hours of injury, and those who require massive transfusion. And it didn't affect transfusion requirements, but their outcomes came up. There's a lot coming out about TXA, though, and using it in the wrong people, and how many of those people are going to be clotting, and that's what we want to avoid, too. So the problem with CRASH-2 also was that less than half of those patients actually required surgery or blood transfusion. So giving it to people who are not in hemorrhagic shock could be detrimental as well. And what about vasopressors? Well, we know that people who bleed also are going to be hypotensive. They're going to be in SIRS. And there's mixed reviews whether or not using this early in patients with hemorrhagic shock is going to help or hurt. It used to be a bad word that you would use in at least acute hemorrhage. But the study is looking at that now to see whether or not that could be a potential use in early resuscitation. So point of care testing, how do we monitor our endpoints? Well, there's a lag in the lab. I got that patient from the emergency department to the operating room in 21 minutes. Viscoelastic and hemostatic assays are going to take at least 30 minutes to get your results. Coags, labs, all those sorts of things. So, and if someone is acutely bleeding in the field, their hemoglobin is going to be exactly the same as it was 3 minutes ago to them bleeding. If they can lose 5 liters of blood, and their hemoglobin will be exactly the same. They haven't had time to equilibrate. So we don't know how well labs are going to tell us about our endpoints or even how to direct our resuscitation. So viscoelastic hemodynamic assays such as ROTAM and TEG are used, but I think there's more use of it later on in resuscitation, and protocols really haven't been shown to help direct this. And other factors such as hypothermia and hypocalcemia have to be paid attention to in these patients too, with all the blood products they're given. And of course, even in the warmest climates of Houston, for instance, people get hypothermic from resuscitation, but also from the trauma itself and acute hemorrhage. So areas of further study, there's a lot. We're still trying to figure out what the best timing of all of these treatments are. And hemorrhagic and shock with combination of brain injury is an especially challenging patient population, because those two things in combination are what kill most people in the first 24 hours of trauma. Use of coagulation and diagnostic and therapeutic tools. How do we monitor people who are bleeding? Because sometimes people bleed 6 liters in 2 hours, and you can't keep up with that with lab values. And then timing of blood products and endpoints of resuscitation. I think ultrasound is really going to come into play a lot in people who are in hemorrhagic shock. It's something that you can reproduce. It's something you can do quickly. And so I think that that's going to becoming more and more what we use to monitor resuscitation. And then what do you do with all of this that we know about resuscitation in places that have limited resources, places that are in trauma deserts, for instance. In the middle of Montana, I think there's one trauma center for the entire state, and that's a big state. So it's hard for us to translate this to that. And trauma systems are what we're looking at for those sorts of things. So thank you.